So we're back here at the F8 TV studio, day 3 of the European Pain Conference.
Yes.
So late September in Budapest.
Yeah.
And we've been very fortunate to catch up with Professor Michele Sterling. You're from the UQ, so the University of Queensland.
Yes.
In Australia.
That's right.
Which people will pick up on your accent in a moment. You are a physio by background.
Yes.
And you've really made an impact in the world of neck pain, particularly within whiplash and traumatic neck pain.
Yes.
So beyond that, what's your sort of role? Where do you sit and what do you do on a daily basis?
So I'm fortunate enough to have a research-only position, a fellowship through the NHMRC. So most of my day is managing a team. I've got quite a large team now of people. We also receive funding from the Motor Accident Insurance Commission of Queensland and have done for a long time. So our focus is on road traffic injury, particularly improving outcomes for people with whiplash injury. It's the biggest cost driver for our regulator, our state regulator, so that's why they're interested in research of it. Yeah.
Sounds like a good strategy.
Yeah, I've been working with MACE, as we call them, for a long time now, and they're particularly interested in our research, I think, because it has such clinical relevance, and you know, my goal is always to try and improve treatment for people with whiplash injury in particular, and particularly physiotherapy treatments, because I think physios play the biggest role and the most important role in helping people after they've had their injury.
I'm going to go with this, so just yes or no. Can we treat successfully people who have had a motor vehicle incident and they're diagnosed with whiplash?
Can we successfully? Yeah, well, I think we can. I think in the last 10 or 15 years we've learnt a lot more about the condition. I mean, it certainly is heterogeneous. There's some people that have a very straightforward clinical presentation and they will do well probably regardless of what we do.
Okay, so for everyone listening, this is the topic, isn't it? This is what we're going to go into, and I just want to jump right to the end of it and then come back. So historically, so you are out of I think you did your undergraduate and your graduate. You've done everything at UQ, right? So
no, I did my grad certificate at Curtin in Perth.
Okay.
So undergraduate and PhD at UQ, but I went over and worked with Bob Elvey and Max Zussman for my postgrad. It was postgrad diploma then, now a master's, clinical master's. So yeah, that was a long time ago, but that really turned my career around, I think, to be honest. Yeah.
Why did it do that?
Oh, just looking at pain in a different way. It was around the time that the knowledge about pain processes and things was exploding, and so I'd been a clinician already for 10 years and struggled a bit with some patients that we felt like I couldn't help, and this sort of just shed new light on why that might be, and understanding the plasticity of the nervous system and so forth. So yes.
And if we go back, so when I say UQ, I automatically think of stabilisation and this whole construct about, so it started out in the lumbar spine, but it moved up to the cervical spine as well. So in a historical perspective, what did that bring us? Where did we come from, and how did we get there?
How did we get there? Well, I think it was a good hypothesis. That the deep stabilising muscles, there was something wrong with them, if you like, and that we should rehabilitate them. But to be honest, the more recent research has shown that it's much more than that. How I look at those exercises, I guess, is as any other exercise to get people to start moving, particularly those that have a lot of pain and allodynia and fear of movement, as a way to start movement happening, but needing to progress them along the line, but also needing to consider not just muscle function and movement, but pain mechanisms and psychological factors, which is so important.
And what I want to highlight here is that, and I think this is a quality that I would, encourage more people to have, and acknowledge that you have, is having a theory and testing it, and actually rigorously sticking to testing the theory instead of proving it. But having this idea of falsifying it and trying really to be as objective as possible, with, of course, biases and all of that. So could you let us in on your personal sort of adventure, I was almost going to call it. So So I imagine you come from this, amazing time where we thought we had it. I have the book back home, right? The stabilization exercises.
Yeah.
And we had it. I mean, there was wonderful studies done where you probe people down the throat they do neck exercises, and we were all doing that.
It was always a bit strange to me because I could never really understand what was the purpose of these muscles switching off or whatever they did in an injury. It's a very strange evolutionary concept. If you have an injury, then all these muscles go haywire. So, I lived through the era as a physio where we were micromanaging the scapula and to a millimetre of its life, and I have to admit I always thought it was a little bit unnecessary probably, but that was to go against the grain of things at the time. I mean, I think learning more about pain sciences, and then I did my PhD looking at a cohort study of whiplash people and see if we could predict outcome. And I remember the day I plotted the graphs of looking at cold hyperalgesia between different groups that recovered and didn't. And it just blew me away. There was this clear difference that the people that didn't recover had hypersensitivity to, cold, heat, just pressure, right from the word go.
And what you did there was that you had a group of patients who had been in a vehicle accident, and then you tested them. So you essentially you put something that is cool or cold on their skin.
Yeah.
And you asked them whether that is cold or painful.
Well, we had better equipment than that, so we could measure the temperature at which they said that they first found this cold stimulus to be painful. So, and compared that. So healthy controls and people that recover after whiplash, they'll feel pain. Yeah, it'll be about 9 degrees, under 10 degrees, whereas these patients were telling us it was painful at 20, 25 degrees. And they separated out clearly. And so that, I thought that was, really exciting. And then the other thing I think that emerged that was interesting to me and maybe now to people isn't so exciting, but the issue of post-traumatic stress symptoms I'd never considered in something that we think of as a minor injury, if you like. And in fact, when I've presented research about PTSD symptoms, sometimes I'll get a comment that, they can't have PTSD, you have to go to war to get PTSD. So that was interesting as well. And I have to admit that I'd then think about patients I'd seen with whiplash who were scared to drive. 9-10 months later, they still weren't driving, weren't sleeping because they'd have nightmares. And I just sort of think, that's interesting, but let's do some exercises. I hadn't really thought how potentially important those factors are on their recovery. And if you're sort of 10 months post-injury and you're still having fears about driving and nightmares, it's not a very good place to be.
So it's interesting you have this dual approach where you have the person and the experiences and all that goes in with PTSD as you mentioned, and also have this quantitative approach.
Yeah.
So if we could just for a minute just talk about quantitative approach. I don't know if people who are listening here understand why it's interesting that cold sensations change. So just a little bit of insight. So when we are injured, especially like if you have a cut on your hand, we all have changes in how we perceive a heat stimulus.
Yeah.
That's very normal, and also pinpricks or a mechanical stimulus. That's really normal. But we rarely see changes in cold.
Yeah,
this is what you found.
Yeah, and to be honest, I don't think we really know the mechanism underneath it. We think it's probably something to do with the way, altered nociceptive processing. But it's not only a predictor of outcome following whiplash injury, it's also been involved with predicting post-surgical chronic pain, tennis elbow. So there's something about it, but to be honest, we don't know what it is reflecting, I guess. So
do you think it's a phenotype? Do you think these are
it's interesting
people who have a different phenotype?
Because we have got a paper under review at the minute where we're looking at the trajectories of these measures over time, and it looks like we're hypothesising that the people were probably like that prior to the accident. So whether there's a more pro-nociceptive phenotype, that then they're the ones that are vulnerable to develop chronic pain, whereas and it related cold hyperalgesia related well to their disability trajectories, but pressure pain thresholds not so much. So it's interesting space, and you do wonder whether there is some inherent vulnerability in people.
And I guess one of the things that is so tricky when we deal with chronic pain is that if you have a group of people, like 100 people, who are all exposed to the same thing, in this case a vehicle accident, not everyone will develop acute pain, and definitely not everyone will maintain having pain.
No, exactly, and I think that's with any chronic pain, that the interest, isn't it, that some people do well for a given injury, and I think for many years we hunted around looking that maybe they had their neck rotated and the forces were greater, but that evidence hasn't really, there's been no evidence that makes any difference. So, and it's the same for pain, it's the same for PTSD. Some people are fine and resilient and others aren't. So it makes you think that, there's some inherent biological vulnerabilities to develop these sort of stress-related, pain-related conditions.
And I guess if we thought that, then it would be really difficult for us to also think that we could help these people.
I think, I guess people argue if they're already vulnerable, what can we do? But I think there is things that we can do, and at least it alerts us to that these people that are more at risk need a different early treatment. I won't say more treatment, because I don't want people to start doing lots and lots of treatment, but more targeted treatment, not necessarily more numbers of treatments, and targeting some of these factors if we can.
So in your perspective, as the expert on the field, if there was let's say a genetic component that makes a group of people more vulnerable, and just for the sake of it, let's imagine that same thing that makes them vulnerable to one thing makes them better at something else, so it's a balance act. But if they are in this vehicle accident under certain circumstances, they're more prone to develop this pain. Does that, in your expert opinion, mean that we should focus immediately on the things that are not pain related, because the pain might be more genetic, as it were? Or do you think we should still try and change the pain? Does that make sense?
Yes, I think so. I think I know what you mean. I mean, I think in the acute stage we should try and help them manage their pain, but that could be through different ways. So it could be through managing their stress, it could be through managing their fear, not necessarily specifically targeting their pain. And I think, there's genetic vulnerability, but there's also prior life events that could render them vulnerable. So early life trauma, previous trauma, we know those things change the brain and change the nervous system. And certainly it seems that a lot of people that develop chronic pain after road traffic crash injury have had previous traumas in their life. So that's another thing to bear in mind, I think.
Has that been compared to a background population? So I imagine many people would have had trauma at some place in their life, and it's easy to say, so therefore you have whiplash. But do we know if that's true for the background population as well?
Yes, probably. I mean, it is. I think you're right. You can't sort of pinpoint in every individual patient you had trauma, so you're going to get chronic pain. But there is a link there to think about, I think. And there's some interesting data coming out from the US in a large study where they have followed people in the ED, about 5,000 people from the time of a presentation in the emergency department, and followed them out over time. And there are interesting results coming out showing that, and in our studies we've sort of recruited people around 3 to 4 weeks post-injury, because that's sort of the earliest we can feasibly get them. But they're showing these changes happen the minute they're there, or maybe they're there the minute these people turn up at the emergency department. So that's another. What
would be what do you think is the mechanism there? Are you think we're working on maybe the PTSD aspect of it, or?
Yeah, I mean, I think that's really important, and that's been overlooked a lot of the time. The people that develop chronic pain, that there is some argument that it's a stress-related condition, whiplash, more than a physical injury per se, and this vulnerability to not be resilient to stress and so forth, and then that in tandem, chronic pain develops. So certainly I think these sorts of things are worth looking at in patients.
If you would excuse me for not remembering the first author, there was a study done in Quebec 10, maybe 15 years ago, where they looked at people who were in a car accident and the number of people who had whiplash associated disorder after that, so pain after that, and they compared that to the background population in Quebec, and they saw a similar amount of people. So what do you think of that? So I guess what I'm saying is, does that suggest that these people would have had neck pain even if they weren't in an accident?
I guess I
are
don't.
they different groups
I
of
think
people?
they're different. I don't agree with that. I can't remember the exact details of the study, but I think that evidence suggests that whiplash is different from non-traumatic neck pain. For one, the PTSD side of things, I've got a PhD student at the moment doing a systematic review trying to compare them. They report more pain, more disability clearly, and the sensory changes are probably different as well, the hypersensitivity of pressure and cold stimuli.
I haven't seen that in non-specific neck pain.
Not as much. People say it's there, but it's not as much, do you know? I think there's a continuum of it, so sometimes you've got healthy controls, and then things like tennis elbow, non-traumatic neck pain are a bit hypersensitive. Whiplash, the worst whiplash people are more hypersensitive. Then fibromyalgia is the ultimate end of that scale. So my feeling is they're different. I get a bit annoyed, I guess, when people clump them together as just neck pain, because it is a traumatic event. They'd had a trauma, and I think that's the difference between whiplash, obviously non-traumatic neck pain, but even low back pain as well.
I think it's quite deliberate when you say they had a trauma, because some people think that, and definitely that was the old way of thinking, the neck had a trauma. So it was all about the things that happened in the anatomy and biomechanics. But I almost take it from what you have said so far that you don't believe that's the case, but the person has been in a trauma. Is that true?
I think they have had some sort of injury. There's something probably injured in their neck. And as with any other injury, that's then complicated and confounded by the psychological presentation. Something tips them into this hypersensitive central nervous system state, which I don't think we quite know why. And I do recall a paper a long time ago, I think it was an animal study, where they showed that hypersensitivity was greater if you injured the neck. So perhaps it's a highly vulnerable area near the brain. It's responsible for our vision and our hearing, and if we're threatened around our neck, it's a big threat, and whether that has something to do with it. There's still some investigation going on, looking at whether there is some sort of neural injury associated with whiplash. We tried to have a look at that a long time ago and sort of ran into a brick wall a bit. We couldn't find anything specific. It was still very generalised, but Nina Schmidt in Oxford is looking at using a variety of methods, looking to see if perhaps I think it'll be in some people, it won't be all of them, and that's the difficulty, is trying to, how do you sort of sift those people out?
Yeah, I guess because you said this at the beginning, that the people who end up with the diagnosis of whiplash-associated disorder are not a homogeneous group.
No.
But they may share features, and one of those features is the trauma.
Yes.
Do you see anything else that they would share, which is not common for people with non-specific neck pain, for instance?
Well, I think the trauma, the psych presentation, and then the central change of the hypersensitivity, it seems to differentiate them to some extent.
So yeah. Sometimes in at least in the area of low back pain, there's this argument. I don't think there's any supportive data, but there's this argument that if there's a good reason for your pain, let's say you had a herniated disc, and then the pain started, then that narrative is easier to sell, as it were. So it's more sociable, and people understand your back pain better. And I would say that's sort of a protective mechanism, because you can explain why you hurt, as opposed to someone with fibromyalgia or low back pain without any onset or gradual onset, where you don't know what it is, and you're more prone to coming up with these wear and tear explanations or degeneration explanations, which are less likely to explain the pain on a mechanistic level, at least. So my question is, do you think that the people with whiplash who had that trauma, are they better off, as it were? Is it easier to explain their pain as opposed to someone with non-specific neck pain?
I think so. It possibly is. I think, they know they've had an injury, and so what I would say to them is, there is probably something that's strained in your neck, but we can't really tell what it is. But those structures will heal, With non-specific neck pain, I guess, non-traumatic, I sort of call it, I guess, something similar could be going on. I think it's hard to say to patients, you've got pain, but there's nothing causing it. It makes no sense whatsoever. It's how you frame it and what context you put it into, I think.
So let me see if I get this right, because I think what you're saying is that whiplash-associated disorder or traumatic neck pain is not just non-traumatic neck pain with a trauma. There's something else to it.
Yeah, there's something else to it, for sure.
And can you elaborate a bit on that?
Well, I think, as I've mentioned, I think there's something to do with the stress response of the whole injury.
So something within that person or
their
within
response,
the trauma?
in the trauma, their response to the motor vehicle crash, their traumatic, how they perceive that.
Yeah. Was
it life-threatening? Did they think someone was going to die? Did somebody die? In fact, some people do have quite severe trauma. The car rolled over, or we've done a lot of interviews with patients and recorded them and listening to them and how they tell you about the accident. You can tell they're traumatised. Their voice is quiet. They sound like they're upset. This is, years down the track when they recall it. A truck was coming straight at them. Obviously it missed them or swerved away. But that, the psychologist will say that sort of thought that you might be going to be killed or someone else was going to be killed can influence all the stress systems in the body, and that, I think, is what complicates whiplash to a certain extent. I mean, not all people think like that, but a lot of them you talk to, if we ask them, we often don't ask them, do you know what happened to your accident? But if you ask them a little bit more about their experiences, it has been quite traumatic for a lot of them.
Do you think, would it be feasible to do preventive measures of some sort? So other than, of course, avoiding car accidents altogether, would it be feasible to do, I don't know, educational strategies or? I
guess so. I mean, avoiding mobile phone use might be a good place to start. Avoiding rear-end collisions for people being on their mobile phone.
Yeah, because it increases the risk of crashing.
Yeah, it does, and it's a big problem for our system. A lot of whiplash is caused by someone being on their mobile phone.
Oh, really?
Yeah. So they have a big drive to decrease that. So that's one place to start. I mean, I don't know, do you go to a public health campaign telling people, driving on the road is dangerous and you should take preventative health measures? I think people know that to a certain extent. There's always a risk with driving cars. But
with all respect, there are greater risks than having neck pain.
That's
with
right.
With all respect, of course.
But I think if primary healthcare providers can understand the trauma that some people have gone through and the stress and help them deal with that, would go a long way.
I guess what I was fishing for was, do you think that the first responders, they obviously need to take the worst case scenario approach?
Yes.
Could that be part of a problem as well? Could that be, stimulating or facilitating a more catastrophizing or whatever?
Yeah, no, I'm sure, and I think the first responders, their job is to make sure that person's alive and get them to hospital. So sometimes they do put them in a collar, and I've had patients tell me they were frightened, they didn't know what was going on. They're taken to the ED, but not all of them are. A lot of people walk into ED the next day with neck pain because they're worried. But then the emergency departments too, I think, could do. I'm not criticising them because it's a very challenging environment. At the minute, it's worse than it ever was. But sometimes a little bit of reassurance would go a long way, especially the medical professionals. I think the patients listen to them, and the patients come out and say, I don't know what's wrong with me. They did an X-ray, they did a CT, and then they muttered something, and now I'm here and I don't know what's. So just sort of some explanation. Of course, we have physios in emergency departments as well now around the world, so I think they play a big role in perhaps understanding that these patients have had a trauma, and they could have an active role in trying to prevent the later sequelae just by what they do in that early stage.
Could we try and make sort of a chronological case? So first responders, there's only so much they can do. Now you come into the ED, the physios you meet there could give you a reassuring message about we know what it's not you, and then they would tell you to go home and do whatever you want
we've
to
developed
or can,
some
or...
materials for the emergency department, an advice booklet to give patients, which they do, which just tells them a little bit about the injury, what exercises they can do. There's some stress relaxation techniques in there, talks about stress being common. And so that sometimes can help save the physio's time as well. But generally then it would be in Australia that then if they still had problems or weren't recovering to take the next step and go to see their GP. So there's often no formal follow-up of the patients.
What would you say? So it sounds almost like concussion to me. So people were told there's, generally speaking, there's a really good prognosis. Most people recover quickly within, we usually say 2 weeks, without really knowing if that's the case, but at least within the first sort of 4 weeks. Is that a similar trajectory you would see, that most people after a vehicle accident will go fine?
I mean, I think, the data would say that 50% of people won't fully recover.
Was that 15?
50.
50%,
but some of them will only have milder levels, so about 25% will have moderate to severe pain and disability.
And these are people who may have had trauma before, but on the day they were supposed to be pain-free?
That's what they say, yes.
And then 50% of this group, when you measure again 1 year later, will have symptoms.
Of some degree.
Of some degree.
Yeah. And so saying to people, I think this is a bit of a vexed issue, saying to people, well, most people get better, so don't worry about it, and then they don't get better, what's wrong with me?
Exactly.
But then you can't say, look, I'm a bit worried, I don't think you're going to, that's not a good thing as well. But when I think of other conditions, for example, cancer, people do get a prognosis. Maybe it's a way we can say things such as, we do this, we have a patient resource, and so we'd say things like there's features, in your presentation that may mean you have a slower recovery, but here's some things you can do. This is what you should do, and make some suggestions to them.
So still keeping that positive,
yes,
supportive message.
Yes, so you're hoping you can avert the course, of course, and if they're going down a chronic pain pathway, our idea is that we can prevent that by better early treatment. But just by saying to people, most people get better, you'll be right, see you later, I think does more harm than good sometimes when they are struggling down the track.
Yeah, because again, one in two are.
Yes, exactly.
So we might as well be frank and say there's a good reason that you may have this, and then you could, I guess, tell them to live as normal as possible.
Yeah, getting back to activity, so we sometimes even, would liken it to, it's like a sprained ankle. If you don't move it, it feels worse. If you sit there and don't do anything, so it's you're okay to move. A lot of them are still frightened. They think that the emergency department or whoever's missed something, which, we say, well, that's just what EDs are good at. They're very good at picking up if there's something. So if there's nothing serious there isn't. So it's important to start moving. You're not going to do more damage. They often had people think, I can't do this because I'm going to do more damage. So all those sort of things that are applicable to musculoskeletal pain, decatastrophizing the people, building their self-efficacy, that they can do it, that they can manage their condition right from the word go, see if you can get their confidence up that it's not something they have to just lie on the bed and wait for someone to do something to them.
So let's imagine this fictitious patient who were going along and they got the messages, everything was done right, but they still have moderate to severe symptoms 3 months down the line. Would you suggest that at this point treatment changes, or are we significantly, or are we doing the same thing as we did before?
I think if they've had the treatment's been evidence-based, it's been good
so
treatment.
So they got good education, they've done some exercises, they're normally active, they're doing what they can, but they meet a limitation.
A few things I'd look at then, obviously you just can't keep going forever, especially if they're self-managing now with getting themselves moving and they're back at work and they're getting back to doing what they want to do maybe. But, as I've said before, something that's often overmissed is the PTSD component.
Yeah.
And we've certainly had people that have volunteered for research down the track and no one's even considered that. So at 3 months as a physio, if they still had significant PTSD symptoms, I'd be looking at referral to a psychologist to help with that. That's just one thing it could be.
Yeah, so at this point, if they still have issues that are influencing the way they live their lives,
yeah,
then you start considering multidisciplinarity or multimodal approaches like psychology.
Yeah, I think you've got to think, why aren't they recovering? I mean, we know that injuries can take a long time, pathology to heal, but really by 3 months, they should be getting back to doing what they were doing and things should be settling down.
Yeah.
And as I said, in our experience in whiplash, that's often what is overlooked. So my first thing would be, well, what are their PTSD symptoms like?
And what does the toolbox, as it were, look like? So there's psychological interventions. Are there any pharmacological interventions that are useful for this group of more persistent pain?
There hasn't been much research on medication, pharmacological, less hardly anything. So we sort of rely on the low back pain field, I guess. So it's the standard recommendations of simple analgesics. Don't go down the opioid path. Very early pregabalin to see if we could settle down central sensitization. It was really a feasibility study because we wanted to give it very early.
So pregabalin being an anticonvulsant,
yes, that's
and
right.
supposedly
And
it will drive the descending modulatory system.
So we wanted to give it very early. So we, in the emergency department, sort of within 48 hours. We don't know what time frame, but that's what we picked. And it was we did get, it was only a small study, small feasibility study, but the clinical results looked hopeful. So we do have funding now for a full trial, which is about to start. So we'll find out the answer once and for all, whether it's any good or not, as a preventative measure.
And what about other medical specialities? Would they, at this point, I mean, could a neurologist support and find out if there's an underlying neurological disease?
Well, probably only if they had a radiculopathy, I think.
Yeah.
So some of them will get a nerve injury, have a cervical radiculopathy, and perhaps they need assessment if it's progressive, particularly. I mean, the other medical specialists do get involved, but it's usually at the instigation of the insurance company. I don't know, they necessarily need to be involved. And what we hear from the insurers is that they often will bring in the medical specialists so that they'll also tell the patient that they don't need, reassure them. So these days, at least in Australia, there's not as many people pushing for surgery and that sort of thing. So yes, they do get involved.
Surgery, is that an option? Is there anything to surgerise on?
Not really, unless they've got instability, a fracture, a dislocation, I guess. That WAD 4, that would be about the only thing. Potentially, maybe a radiculopathy, WAD 3, in certain cases, but I can't see of any.
I guess this is the clinical dilemma to some extent, is that at a certain point we stop believing that the pain itself will just diminish over time and go away, because maybe on a long time, maybe 10 years, but not within. So if and at that point, what I hear you say is that you start changing slowly the way that things work, so that we get more into the self-help, psychological therapies, support.
I think we start that from the beginning though, so not wait until the person's not recovering. So I would be starting off building their self-efficacy early, looking at their stress symptoms, but as with pain, a lot of people that show early stress symptom or post-traumatic stress symptoms will resolve, but there's still strategies we can help them with to explain that. Sometimes it's just telling them that a lot of people have these symptoms. Oh, really? You mean it's just not me?
Yeah.
No, you know, you've had a car crash, it's quite a stressful event, but things will often settle down, just give them time.
Yeah.
So starting in conjunction with usual physio of exercise and getting them moving, but starting those strategies,
Early
particularly in the distressed patient, and then watching how they go, you know, and if these symptoms don't resolve, then it's time for us to, you know, I mean the PTSD symptoms in particular.
You're really not saying, you're saying that we shouldn't necessarily do a step care approach, but in fact when you identify something,
exactly.
you would go for it.
Yes, I think
early on.
Yes, I think we should be more targeted early on and not sit and wait, because we sit and wait and then by 3 months we go, oh my goodness, someone's chronic, and then now what do I do? So early care, early targeted care to those that need it. You wouldn't do the same approach to someone who's low risk and is going to start talking to them about stress symptoms. They go, oh, I'm okay, you know. So you just let them get on with it. Don't treat them, but again, build their self-efficacy. You don't need me. Look, you're doing, you know, here's some exercises, you can manage this.
Nice.
I think is so important.
Yeah. I guess we won't take much more of your time, but what I'd like to ask you is in maybe reflecting on a career, having, you know, built a whole research around this topic and being absolutely one of the leading experts in the world, what do you think is going to happen? What do you want to look back on in 10 years' time and say, I'm so glad we did this, or I'm so glad we achieved this?
Well, it is a good question, because sometimes you wonder whether you've made much difference, you know, to patient outcomes. I think we all do that with musculoskeletal pain. The problem's getting bigger, so where to now? And I think I've sat there and racked my brain sometimes thinking, where do we go from here? This, you know, we did a lot of trials that showed no effect. Well, what are we going to do next? How would I like to see it in the future? I mean, we've got a couple of studies going. One's the pregabalin one, looking at very early care. And I think, you know, once I depart the profession, it would be great to see that people were, you know, evaluated more effectively in the early stage, and more proactive care commenced for those at risk. And hopefully that might avert the course to chronicity for some. Do you know? I think, you know, it's a wicked problem, musculoskeletal pain, and there's a whole lot of the multifactorial things going on, societal factors, cultural factors. We can't change everything, but I think if I can get physios or get better management from our perspective in that early stages, I feel like I've won a little bit.
Yeah. I think that would be an achievement.
Yeah.
I mean, and I guess you're also saying not doing the things that we know doesn't work. So sometimes stopping treatments that don't really have an effect could be part of the bigger picture as well.
No, that's right. We've got to really be careful of the continued passive care. I mean, I think, you know, there's a bit of a perverse incentive in the compensation system to do that they're paid for treatments. And physios, I think, sometimes think, well, there's no harm in it, but there is. I think that's what we've got to realise, there is harm in just keeping somebody coming. You're destroying their confidence to manage themselves. You're making them dependent. It is harmful. It can wreck their lives. So you've got to be on the front foot early on. I'm not saying no passive treatment. I'm a manual therapist, so I would use manual therapy judiciously still, but it's empowering the person to be able to take control of their own health, like we do. Do you know, we do that. So, I think that's so important, and that'd be something that it would be great if it changed, but it may have to come from a funding model change somehow or other. Yeah.
Yeah, I think that's a really strong message to end on. So I want to thank you for your time. I know you have a busy schedule.
That's all right. Thank you.
I wish you a good rest of the conference.
Yes, thank you. It's been a great conference.
Yeah, it has. It really has.
Yeah.
And it's been